Muhammad, I like your background. I see the Egyptian flag.
Ladies and gentlemen, it gives me great pleasure to welcome all of you in webinar number 22 among the series of webinars organized by the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies. As second vice president of the World Federation of Neurosurgical Societies, I understand that one of the important missions of our organization is to promote educational activity among young neurosurgeons, especially in the developing countries. I would like to express my sincere appreciation to our honorable guest speaker, Professor Osama El-Mifti. He's a well-known neurosurgeon and he has an outstanding contribution to the specialty of neurosurgeon all over the world, especially in the field of skull-based surgery. I also appreciate the contribution of our speakers, distinguished speakers from Egypt, Professor Hussam Al-Husseini, professor and former chairman at the Department of Neurosurgery at Ain Shams University, honorary president of the Egyptian Society of Neurological Surgeons, and honorary president of the Pan-Arab Neurosurgical Society. Professor Amr Safwat, professor and former chairman of the Department of Neurosurgery at Cairo University. I'd like also to welcome our chairperson, Professor Muhammad Al-Fiqi, professor of neurosurgery at Alexandria University, honorary president of the Egyptian Society of Neurological Surgeons, and honorary president of the Continental Association of African Neurosurgical Societies. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your experience and knowledge with young neurosurgeons, especially at this time of COVID-19 pandemic, is well appreciated. I will be honored to be the moderator of this session together with Omar Youssef, professor of neurosurgery at Ain Shams University, and Muhammad Seliman, lecturer of neurosurgery at Cairo University, and he is now a fellow at the Western University in Ontario, Canada. Before starting our scientific sessions, I will be honored to introduce Professor Osama Al-Mifti through a short biography. Just give me a few seconds to share my screen. Professor Osama Al-Mifti was born in Damascus, Syria on April 20, 1947. He was graduated from Damascus University Medical School in 1972 with scholarship awards. Then he joined the neurosurgical training program in West Virginia University Medical Center and completed his training in 1978. He then moved to Saudi Arabia, became staff neurosurgeon and chairman of neuroscience department at King Faisal Specialist Hospital in Riyadh. He then returned to the United States of America and he was promoted to be a professor of neurosurgery at the University of Mississippi Medical Center. He became the chairman of neurosurgery at the University of Arkansas from 1993 to 2009. Currently, he's the director of skull-based surgery program at Harvard Medical School, Boston, Massachusetts. For decades, he was working hard for promoting neurosurgery, especially in the developing countries. When we speak about Osama Al-Mifti, we are speaking about more than 500 publications that include authoring or editing 9 books and over 236 peer-reviewed journal articles. We are speaking about over 1,000 presentations and over 90 visiting professorships in national and international universities. He has been a faculty member and director of over 50 workshops and hands-on courses. He was awarded the Oliver Corona Medalist, the Magnus Medalist, Cushing Medical for Excellence and Innovation, and the Medal of Honor of the World Federation of Neurosurgical Societies. And recently, in recognition of his outstanding contributions in the field of neurosurgery, he won the Scoville Award anonymously, and he will receive it next year during the World Congress of Neurosurgery 2021 in a big celebration in Bogota, Colombia. Congratulations. My photo with Osama Al-Mifti brings me pride and honor. Now I announce beginning of the scientific sessions. May I invite Professor Osama Al-Mifti to start giving his first presentation.
Professor Gandour, thank you so much. I am humble and I appreciate it. I really appreciate the chance to be with my very dear colleague in neurosurgery in Egypt. It's just a different life there. A, now, do you see me okay? It's just a different life. I can't help it but to say that I sing a lot a song that says ساكن في حي السيدة وحبيبي ساكن في الحسين وعشان أنيل كل الرضا أروح له في اليوم مرتين for عشان أنيل كل الرضا اليوم حأعمل محاضرتين لأنه حبيبي في الحسين.
It's our
Thank
honor.
you.
It's our great honor.
So if you allow me to share the screen, I'm sorry if I'm going to take too long time. I will condense and I do want to hear what the Professor Al-Husseini had to say and what Professor Safwat has to say. And I want to hear the comment and create discussion. So I do want to leave some time for the discussion and me to learn something from you. I'm always looking forward to learn something from you. Now, a is it sharing?
Yes, perfect. Yeah.
Yes. Okay. Now, here, I want to kind of bring a different perspective today. You will hear beautiful and tips about acoustic tumor surgery and how to do it very well. You will do acoustic better than I do. And you know about it more than I do. But I want to bring a different perspective to the whole subject. This is my disc. And you could see what's on it. Every possible hearing aids. Loss of hearing is an enormous disability. Loss of hearing is an enormous dysfunction. And the hearing, it's a matter that really need to be our goal to preserve and cannot be dismissed lightly. So my concentration on acoustic is hearing. So I want to title this Acoustic Tumor, I Want to Hear You Now. And here where this is camp, you know, right where I'm sitting, There is this library which has in it every little correspondence Dr. Cushing kept about every patient, the greatest database you could imagine. And you could see his agony. This is one of the patients in this record with he's sending a letter. And you could see his agony over how the patient had a facial nerve paralysis and ended with the corneal keratitis. That led to the fear that we induce deficit. And that what made him do only subtotal resection. All of that book, 30 cases, subtotal resection. Then, as you know, Dandy came in and said, we'll take it out. And he took it out. And the quest here was a cure. So this concept of control versus cure has been in our blood from day one in schwannomas. Cushing said subtotal, then they said total. Cushing looking for safety, Dandy didn't accept, he accepted the risk. The subtotal is really control. That's what we say to do, control the tumor, control the tumor. What control the tumor? In temporizing. Just stay quiet for a while. While the total removal really give you cure, and the cure is lasting. With subtotal, you don't have a complication, you looks good. But with total, if you get a cure, you're really doing good. Then these gentlemen came in, House, Kersey, Yazergil, Malus, brought the microscope to acoustic tumor, and they changed the whole world. Now we could do acoustic excision with safety. Now you could do with preservation of the facial nerve. And then Professor Sami came in and taken it a notch higher, that we could preserve hearing too. And you know this article with 1,000 cases he had when he addressed the hearing preservation. So here what you all, and Professor Omar, if you take a voting on the chat, you know, acoustic tumor comes into Baba Bear, big giant, which affect the life, or Mama Bear, kind of medium size, but they might have dysfunction and deficit, or that little tiny baby bear, the intracanicular. The only thing here at stake is the hearing. So, and we have three means today. We call them surgery or radiation or observation. So take a survey, the first one up on top, the Papa Bear. You do surgery or radiosurgery or observation. The second one, the Mama Bear. Do you do surgery or radiosurgery or observation? And the last one, would you do surgery or radiosurgery or observation? We will compare the numbers at the end of the lecture to see if I convinced anybody. Are they voting, Dr. Omar? Now,
Yes.
okay, well, good. So for this, I think everybody said surgery. But before we go there, of those three main presentations, we're having an increasing number of this. A little tiny schwannomas. It's not into the canal. It frequently either has a very severe dizziness or hearing loss. And obviously with the MRI, we're discovering a lot more of them. It used to be oddity, but now with a good MRI, especially with the Fiesta, you could find a very tiny schwannomas. So what do you do with those? What are these? These are known for a while with the name intralabyrinthine schwannomas. They suppose that they are present in the vestibule and they might then extend into the cochlea. They might start with some vestibular symptoms, but they lose hearing because they went into the cochlea. They more and more, there is a study about them and understanding them, and they are now classified of a different stage. And then there is the question, where they originated from. Now, we all know that the acoustic tumor, we learned for 150 years that it come from the junction between the glial and the Schwann cell. Right there it starts. The upper Steiner-Wittlich zone. Well, in this article, they said no. That zone, it's only few millimeter away from the brainstem. You got acoustic that start in the meatus, and more, you got acoustic that start into the cochlea and inside the labyrinth. So they don't want to take the word name vestibular schwannoma away, not just acoustic neuroma, vestibular schwannoma away, because this tumor could start from Schwann cell, either on the cochlear nerve or the vestibular nerve. And they want to take that start at the junction away because this tumor could start anywhere from the peripheral Schwanns, either inside the CPA angle or way out far inside the cochlea. And they say that, like you see here in the 50, they want to call them no more vestibular schwannoma. They are called cochleovestibular schwannoma. And you could say that the vestibular nerve still have more incidence, but the cochlear nerve, about a third of them from the cochlear nerve. And it turned out to be, for them, it doesn't matter if it was the superior vestibular or the inferior vestibular. We ask on the exam every resident, which nerve the schwannoma comes from? He needs to know that the inferior vestibular. They're saying no. It could come from either side. Now, so with all of the sudden this intralabyrinthine schwannoma, they are not intralabyrinthine schwannomas. They are primary ear schwannomas. That could be in the lumbrance, they could be in the cochlea, they could be crossing from the lumbrance to the cochlea. And with that, then there is a difference between they give a vestibular or they give hearing loss. Now, it's very obvious in a tumor like this, you need to do surgery. And you will see more today about what some trick of surgery, but I think the principle is worked out very well. You expose the tumor, you debulk the tumor, and then you create an intra-arachnoid dissection plane, preserving the nerves and the artery in the wall. You see, you have to get into that intra-arachnoidal plane. Peel one of the others. Here now up going to the tentorium and the fourth nerve. Bring it the upper pole down, always stimulating, looking for the facial nerve. And then lift it off the brain stem. Again, creating that intra-arachnoid, preserving the artery of life, the ICA. Continuous irrigation so you do not coagulate, so you do not burn the nerve. Opening the meatus. Debulk inside the meatus till you find the 7, you see the 7. And then dissect it again off the 7. Intra-arachnoidal dissection. You see that two-hand dissection? And then you could go to the fundus of the meatus, and then you could use the endoscope to be sure of the total removal. If you just follow those simple steps, you gotta have a very happy, smiling patient. So you could smile too. And as you could see, no matter how bad the hearing, you could still preserve whatever that bad hearing it was by preserving the cochlear nerve. This become a bigger deal in a tumor like this. As you see, this tumor does not go far into the canal. It's sitting just in the CPA angle and just at the mouth of the canal. Just a little tiny peak right there. So this tumor origin is inside the CPA angle. We call them the medial acoustic tumors. They're what found they are very giant in size. They are hypervascular because they take their blood supply from the internal circulation. They are severely adherent to the brainstem with compression to the brainstem. You see them in a young age, frequently hydrocephalus. But with all of this neurological picture, they still have, many of them, good hearing. Huge tumor, good hearing. And the reason is, instead of being initiating inside the canal or deep into the fundus of the canal, they're initiated in the CPA angle outside. So when that arachnoid plane change, you could see something exactly like our illustration in this article. Look at the internal canal. It's full with CSF. The tumor did not go deep, exactly like this illustration. That means there is a plenty of arachnoid dissection over the 5, plenty of arachnoid dissection over the lower cranial nerve, but there is no arachnoid against the 7 and the brainstem. So they're more adherent to the brainstem. You could see it in this schematic, it changes. You could see with normal acoustic, there is a double plane against the brainstem. With medial acoustic, there is no plane against the brainstem. Now, but these patients, young and still have hearing. So no matter how giant the tumor, you need to preserve that hearing. And guess what? You have a good chance to preserve the hearing. The thing is, once they are big, don't worry about the hearing. You cannot. So we do translabyrinthine. No, even if they were big, try to preserve the hearing. So that means there is really no translabyrinthine approach. We need to do those from retrosigmoid. So, but retrosigmoid, they said you retract on the cerebellum and bad. Well, you could overcome that by doing a transmastoid approach. And you could preserve all of those nerves by doing intra-arachnoid dissection. What's the transmastoid approach? You could see it here. We skeletonize the whole transverse and sigmoid sinus. So the cerebellum will fall down and you got the sinus flipped anteriorly. So you have wide space without cerebellar retraction. Here what you have, this is the regular retrosigmoid approach. Here the flap. Here what we adding of what we call transmastoid approach, this additional exposure. And you could see that adding this additional exposure allow you to go more lateral, no cerebellar retraction. The position is a supine position with the head turned, the shoulder pulled down, and monitor everything. Monitor the bear, monitor the facial, monitor the 11, monitor the 6, monitor everybody. The incision is really not big or things, it's just the same retrosigmoid incision. The trick is to get the sternomastoid muscle all detached and retracted. So no cutting into the muscle, no cutting into the suboccipital nerve, so they would not have neuromas and pain. Then a burr hole just below the astrium, a small posterior fossa craniotomy like you always do. And then we outline the mastoid cortex and remove the mastoid cortex so we could reconstruct it at the end of surgery. And reconstructing the mastoid, the patient loves it. It tends to be that the hole behind the ear, it's very disturbing to the patient. So reconstructing the mastoid, it turned out to be a very patient satisfaction maneuver. And then you drain the CSF, and that's it. You're right there, the tumor waiting for you. We use the endoscope frequently. And by doing this transmastoid, flipping the sinus out the way, you could bring 4 hands into the field, which mean you could do a good endoscopic with 2 hands while your assistant's driving the endoscope. So the setting is a simultaneous combined microscopic and endoscopic. You got the 2 view all the time for both the surgeon and the assistant. They're hanging right there in your face. So the assistant with the endoscope does not knock the nerve going in and out because he's seeing the microscopic view also. And with this, we took patient like this, medial acoustic, a little tiny protrusion into the canal at the mouth, got perfect hearing. Cystic, and suppose the cystic to be more difficult, because I think the cyst wall is more attached to the arachnoid where the nerve is. So one has to be inside the cyst wall instead of outside. And we're looking, debulking, looking for the facial nerve with stimulation all the time, preserving the labyrinthine artery with intraarachnoidal dissection, lifting it off the 5th nerve, keeping the superior, the petrosal vein intact. And that minimize any chances of cerebellar venous infarction. The 5 nerve is freed, and the tumor upper pole is again the same thing, intraarachnoid dissection. Into the canal. The canal is not open, doesn't need a drill. There is no tumor inside it. A little tumor left over the 7th nerve is being removed carefully. Thin out till you get the arachnoid plane again. Finding that arachnoid plane is the whole secret. You can see it here. No coagulation, so you don't burn the nerve. And here, pre-op, tumor remove, hearing perfectly intact like it was, despite the size of the tumor, ensure preserving the facial nerve. We did the 52 patients with those giant medial acoustic. 10 of them that had a level A before the operation, 50% still have serviceable hearing. But then even if the hearing was less than 50% disable, they made this chart that degrade the hearing. And we call it the 50-50 rule. 50 disable, 50 speech discrimination. Anything above 50-50, we call them A and B level. And they call that useful hearing. You could hear 50 decibel, but you don't understand 50% of the world, then they call that non-serviceable hearing. That means it's dispensable for them. That's 120 decibel. It saved his life. Any hearing, it's a very useful hearing. So every hearing deserves to be preserved, and we should try the technique to preserve it. So this is, you're gonna see a lot, a small intracanalicular tumor. They say 2/3 of them would not change, would not grow. Okay. And you could see that this in 2 years did not grow, and 5 years might not grow. But look what happened to the hearing. He had a very good hearing, and it got lost over time. Although the tumor did not grow, hearing will deteriorate even if the tumor did not grow. So if the hearing important to that patient, if the hearing is the of big value for that patient, then you really don't observe. If the patient willing to have it, the risk of operation for the benefit of preserving the hearing, then I think it's his right to have it. And it's our responsibility not to withhold it and tell him, go home, you don't need anything. Now, you could say, well, we could give gamma knife. So the hearing next day and next month and next year will be preserved. And yes, here a gamma knife and it shrink the tumor. And the first year the hearing will be fine. But then as years pass by, the hearing will definitely will go down and down and down. And 7 to 8%, everybody lose all the hearing. And the reason is obvious because the cochlea get on average 5 gray, and 5 gray is enough to give hearing loss. You need less than 1 gray to the cochlea. So if you want the patient to hear, then there is really no radiosurgery. And I think in the evolution, while microsurgery made us the great human we are, look what radiosurgery might be doing. So how you preserve hearing?
The do
I
and
asked
don't
Sammy.
of preserving hearing.
I think this is the most difficult question, and this Dr. Al-Mafti is a terrible man. He makes always, he asks always a terrible question. And
Well, then I will answer my question. Here, a small conicular tumor. You drill the canal under a lot of irrigation, so no heat. You open the dura sheet. You raise the tumor from medial to lateral, so you don't pull on the cochlear fibers. You see how raising it from medial to lateral. This is just for the biopsy, but you don't pull on it. You don't go too deep in the fundus, so you don't bother the cochlear fibers going into the fundus. And even more, this article from Japan, read it. It's now about probably 3-4 years ago article. They preserve the hearing almost in all the patients. And they preserve the hearing by this trick. You get to the dura, you made a large dura flap. You keep the dura, I keep the dura flap even attached, so it will be vascularized dura. You drill the meatus, open the meatus, raise the tumor from medial to lateral by creating the arachnoid plane. Not go too deep into the fundus because you could remove what's in the fundus with the endoscope. And this is the far lateral one. Here the endoscope got what you want. And then this is the trick. The dura flap you had, you bring it in. Now come on, bring the dura flap. A little fat from the neck. But see the dura flap? You see how the dura flap reconstructed the meatus. And you could put fat on top of it for the CSF, but no pushing. Now see the post-op MRI? The CSF goes all the way down to the fundus, keeping the cochlear nerve bathed in CSF with no pressure or scar around it. And I think that had a big role in the success of preserving hearing. Reconstructing the canal where the CSF kind of full like normal. For the time, I will skip and go to the last thought here. We're living in the dream time. We're living in the functional restoration. We're expecting the paraplegic to walk and the blind to see. And we succeeded. Guess where we succeeded? With hearing. Today, we have this cochlear implant. It's a game changer. It could get a deaf person to hear.
I have on the one hand a master's degree in musicology and music education, and on the other hand, I'm a cochlear implant recipient myself.
They could not even just hear you, they could hear and play music for you. So with this, that means every patient hearing could be restored. That means we should not destroy the ear at any time. That means there is no translabyrinthine approach. But the ear is not enough. The inner ear is not enough. You need the nerve. You need the cochlear nerves. That means in every case, no matter what the hearing is, we want to preserve the cochlear nerves. So here a tumor with a bad hearing to start with, but look at the operation. Here the tumor coming out from the vestibular, looking now for the facial after debulking. opening the canal, finding the facial. See that facial, the orange little band right there? We're pulling it away from the tumor. That's a facial. And then underneath, you see that very white nerve? That's the cochlear. Look at the cochlear. Nice, wide, big nerve. You could preserve the cochlear nerve in many of acoustic tumors. Please save the nerve. If you go to Professor Sami statistic, he preserved the nerve in 84% of the time. That means 84% of the patient, even if their hearing was very bad, they are eligible to hear again with cochlear implant. I have this editorial screaming, save the nerve. I had a hard time getting it accepted, but save the nerve. So now, will you take a survey again for me, Omar?
Yes.
Okay.
Would you like to hear some questions, Prof?
Yeah, here's the question. Is this surgery, radiation, or observation?
Okay, this for all audience and participants, please write your answers. Radio surgery or surgery or both, please. There is some say surgery alone. There is another said surgery or radio, and some said only surgery.
Okay, how about this one?
No, I couldn't measure it statistically.
The second one on the left.
Now all said surgery. Now most of them said now surgery. All of them said most of them said surgery now.
Okay.
Can I
How about this one?
Can I interfere?
Yeah.
Professor Osama Al-Ghanam. Professor Osama Al-Ghanam, you can join.
Hello, Professor Osama.
Hello, Osama. Sabah al-khair.
Sabah al-noor. Good to see you. For the people who don't know, it's not just sharing your name, but sharing the age, the born year. We born the same year, Professor Osama.
Yes.
That's number. Well, you are very lucky. Here in this country, our patients always come with an orange size, a big tumor, and all of them that they're very little. I remember over my 40 years of career, just one or two still having hearing. The professors in universities are sophisticated patients, but most of patients in this country, they are coming with totally deaf. Anyway, and in spite of doing our best to preserve the facial and nerves, still we have high morbidity of the cochlear nerve and the facial nerve up to 20%. We couldn't save it. I know you need the monitoring and other sophisticated things. We're trying hard. The point I'm trying to say that do I do surgery or prefer to do gamma knife or observe? In this country, most of the patients, they refrain from surgery, especially if they said, well, you disturbed my face, I wouldn't talk, I might have so and so on. If you explain them to that, they wouldn't accept surgery. So they leave them till they have the complication. And most of them, they come because of hydrocephalus, of ataxia, of choking, bulbar palsy. They don't come because of the of saving the facial. Then they accept the surgery. But most of them, when they come, especially if they are old or in a hierarchy position, they refuse surgery or they prefer to go abroad. That's a fact you have to accept. The other point about the cochlear implants, that I think nowadays we have a chip. You put it on the brain stem, very little minute chip, and this connect to the cochlear serve instead of the cochlear nerve. That's nowadays, I think, they're present. I need to hear your comment about this cochlear implants, not cochlear implants, this chip implanted or stick to the brain stem. Thank you very much indeed.
Professor Osama, just give me the chance for a few seconds. I am honored now that Professor Luis Borba, professor of neurosurgery and president of the Brazilian Society of Neurosurgery, is joining our webinar. Professor Borba, can you hear me? Luis Borba, are you here? Okay. We then proceed to Professor Osama Al-Mufti again to, if you'd like to answer question of Osama Al-Ghandour.
I just want to finish to see if was any influence on anybody. Because with this, I think everybody will have said before observation. And I want to see what they think now with that small one on the right. Dr. Yusuf, you're keeping
Yeah.
track.
Yes. With you. I'm with you. Yes. I'm s- still seeing the answers regarding this small one, right?
Yes.
This is small one.
Professor, could I?
Yes, please, Dr. Hussam, please.
Well, what Professor El-Mufti presented is something that neurosurgeons should go one step forward. When we started neurosurgery in the 80s, such formidable lesions, you just say, you did the operation in this part of the world, and the patient is still living, and a lot or some had deficits. And then things progressed. Now we are speaking about facial preservation, even in big tumors to some extent. Now we have to go in our part of the world to go one step forward again. The new generation, enthusiastic, have better instruments, better microscopes, endoscopes of all kinds. Then they should consider what Professor Al-Mufti put in hand, that we are speaking about another level of neurosurgery, functional neurosurgery. Morbidity is to a lesser extent accepted, or or put it other way, it's not accepted as before. But if we are still scared to go forward, we'll never progress. We'll stay at the level of the 80s. And I'm sure that we have well-trained young neurosurgeons now that they can carry on and do one step forward than what we did at the beginning, at the late 90s and the beginning of the 21st year. Thank you.
Yes, Professor Mufti. Some people said before your lectures they took the decision of observation or radiosurgery, but after your presentation now, it changed to do a surgery, especially after the percentage of hearing loss after long-term radiosurgery.
Can you hear me now? Can you hear me now? Now. Good. Can you hear me now? Can you hear me now? Good.
Well, thank you. You sure heard me, so I really appreciate it.
Thank you. Yes.
I hope I did not take too long time. I think Dr. Al-Husseini, Professor Hussam has answered the uh, Professor Osama very well. So, Dr. Ghanem, you could take Hussam answer as my answer.
Thank you very much, Professor Osama Al-Mufti, for this great talk. I think you finished early and we have like 10 minutes. We can open discussion now among panels and we can answer questions. I think we have Hisham Basyouni too, who is professor of neurosurgery and director of academic teaching hospitals in Bavaria in Germany. Hisham, do you like to say any comments?
Yeah, thank you very much. Thank you very much, Professor Osama Al-Mufti. And actually, we're celebrating our 20th years of knowledge because it was in October 2000 that I first visited you in Little Rock. I think you remember, and had the great chance to see you and also at that time Professor Yajagil. So getting this really great and yeah, beautiful experience, and this spirit is still with me today. Always remembering when I'm doing any skull-based surgery. I think actually the philosophy is one. I'm sharing the same philosophy in regard to the approach. I'm for acoustic neuromas of any size. I'm approaching them with the retrosigmoid approach, and I'm not doing the transmastoid or the posterior transpetrosal approach. We had a discussion 2 weeks ago in the same webinar, and one of the colleagues of Tanta, Professor Nasser will remember, said he's doing a posterior transpetrosal approach for all the acoustic neuromas, and I actually refuse this idea because you're losing hearing, and we have a good chance to preserve hearing nowadays with monitoring and with very sophisticated surgical measures. So actually the philosophy is one. I'm not doing a transmastoid to enlarge the approach, because I think when you are releasing CSF, even in very large tumors or the small, of course, you have enough space to to handle the tumor appropriately. And in my view, you are increasing the chance of having a CSF fistula when you are entering the mastoid cells, or the more you open, the more chance you have. But of course, you can close them, but you have a chance to increase the CSF, the incidence of CSF fistulas. So I'm actually doing just the retrosigmoid retromastoid approach. Of course, you usually with this approach, you're also entering, depending on the aeration of the mastoid, you're entering mastoid cells, but you can close them, and you have good overview. The cases you have shown, I think you have always to talk with the patient, and that this makes a difference. So the first example, the mama beer, I think everyone will agree to do surgery about it. The middle sister is, I think, because it reaches the brainstem, I think it is a surgical indication. The small one, you have to discuss it with the patient. We know that it will increase in size. Surely, around 1-2 millimeters a year, that's the median, which is reported in the literature. but you have in our days you have to discuss it with the patient, because hearing preservation, even in these small tumors, there's a great chance with surgery to preserve hearing, but of course it is not 100%. So if hearing is lost, and usually these tumors, the facial function and the hearing is well preserved, at least to a serviceable hearing, you have to discuss it with the patient. So I think observation is also an idea. You have to discuss it with the patient, because some patients will say, I cannot live with any tumor in my head and I want the surgery. So that's an easy one. On easy discussion, but some people are very reflective and to discuss, and you have to mention that they can, with surgery, lose hearing or experience a hearing deterioration. So you have to discuss with the patient. I personally, I would support doing surgery on this case, but you have to discuss it with the patient and with the accompanying relatives usually. They do not come alone. So that's my opinion on this cases. And thank you very much for this great experience and knowing you and mentoring me over all these years. Thank you very much.
Thank you, Dr. Hisham, for this crucial comment. We need to welcome Professor Luis Borba. He's joining us now. Yes, welcome, Dr. Borba. Great welcome.
Oh, thank you, thank you. I cannot miss Dr. Al-Mufti presentation. I cannot miss to meet all our friends from Egypt. And
Thank you.
today, what we are seeing in acoustic neuroma is a little bit change. You don't know who is deciding the surgery today. Looks like the company is decide what kind of approach. Today you see the computer decide how much you should remove of the tumor. Now there is a new software, and they call adaptive surgery, that you put the patient in the computer, see the size of the tumor, and this part you can remove, this part you cannot remove. Here is the facial nerve, here is not the facial nerve. It looks like a different world. It looks like a Disney world. Looks like a dream. I dream one day that I do a large acoustic neuroma, that in the pre-op, I know perfectly where is the facial nerve. I know perfect where is the cochlear nerve. But it's not the reality. See, in large tumor, you know where is the facial nerve in the brainstem, you know where is the facial nerve in the canal, but you don't know in the middle. And sometimes you can lose it. More training you have, more experience you have, more careful you are, is lower the possibility to get this deficit. But we are seeing today in the world that they are changing who is managing the acoustic neuroma. We see ENT doing biopsies and send the patient to radiation therapy. We see neurosurgeon doing very small bite in the tumor and send to radiosurgery. And you see lawyers decide what to do with the patient because of the complication. This you can do. But everybody's forgetting one part of this big war: the patient. We know that the only curative treatment for acoustic neuroma is the removal, is the radical total removal. You should at least try all the time, at least try. Sometimes not possible. Sometimes attached to the brainstem, sometimes attached too much to the nerves. You cannot do it. It's the real world. I know that Dr. Al-Mefti is an incredible surgeon. He can do much more than me. It will be much more than many, many, many people in the world. But the reality in the whole world, we should adapt this situation. But first, we have to think in the patient. One thing that makes me worry today, that the radiosurgery should be a neurosurgical business. The neurosurgery could not be a radiation oncology business. We are seeing in Latin America, 70% of the radiosurgery is made by radiation oncologists. The neurosurgeons are not involved in the treatment, are not involved even in the decision to treat or not. The patient sometimes go the ENT to the radiation oncologist for a neurosurgeon that he has no experience, or he doesn't want to do the surgery, send directly to radiation oncologist, and this patient loses the opportunity. Last week, I had one terrible experience. A 25 years old, beautiful lady had acoustic, 3 centimeters, round one, nice, brainstem okay. They decide to do that radiation therapy. Because of the size, they decide to give 4,000 rads. See? 4.0, okay? In several steps, several sessions. 4 years later, a giant sarcoma in the CP angle. Oh, it's very rare. I know that's rare. It's very uncommon. I know that it's very uncommon, but it's happened. But when you see a lady, young, beautiful lady, that had a benign tumor, now you have just 1 year to survive. We have to think what to do with our patient. For a small acoustic, very small, that Dr. Al-Mefti showed, what's the best treatment? Take it out. But sometimes you're not used to do this surgery. If you're not used to do, just wait. Sometimes in 10% of the case, it will decrease. Maybe wait and see should be the second option for acoustic neuroma. My great honor again to see my mentor, to see Dr. Al-Mefti is still moving the whole world of neurosurgery. He still make us think and dream that as a doctor, I had to think first in the patient. I'd like to invite you, all of you, first apologize. Next week you have our first symposium, the Al-Mefti Friends and Fellows. All of you are our friends. All of you should be in the folder. The folder should have 3,000 names, but I'm sorry, you cannot put all of you. Thanks. Yes, next week, Thursday, Friday, and Saturday, we have the Al-Mefti meeting. And all of you will be there to enjoy the discussions with our mentor.
Thanks.
Thank you, Dr. Nasser, and to thank you, all of you. Thank you.
Thank you very much, Luis Borba, President of Brazilian Society, for contribution to our webinar and for your valuable comments. I will be grateful to you if you send us the flyers in order to disseminate it in Egypt and Africa about the next webinars in Brazil. Please.
I'm sending out to your WhatsApp.
Thank you, Luis. And we enjoy if you stay with us. We still have another panel discussion. We will
Yes,
be very happy if you have time to.
my pleasure. My pleasure.
Thank you very much. Now, Professor Muhammad Al-Fiya, I think he have a comment he would like to say it, and then before we proceed to our next speaker, Professor Amr Safwat.
Professor Osama, we enjoyed your presentation very, very much. As usual, you are great as usual. Time have changed, and you have lived and worked in this area of the world. And as you've shown, there are different decisions depending on the size of the tumor. In the presence of radiosurgery and regarding the age of the patient, how would you manage that? That's number one. Number two, is hearing preservation that important if we have 2 ears rather than facial nerve preservation? Thank you.
Hussam, you're always right on the money. You're the perfect question. And I'm glad you raised them because with my enthusiasm or over enthusiasm, I might have not touched on those two very important points you said. Number one, the age definitely played decision in all of our decision. Because the age is not the number of years. The age is the general health of the patient and their receptiveness to complication. So if it comes down to preserve a hearing in one ear that you have a pneumonia and you stay on the respirator for so long, and then you have a fungus meningitis, it's a totally different issue. So I absolutely agree with you. In here, it's not save hearing in all costs. In here, save the hearing when you can for the people who will benefit a lot from it. So the question then came right after that, well, if they have another hearing ear, it doesn't matter. Well, no, it does matter because first of all, it mattered a lot in neurofibromatosis patients. Even if they have a very good hearing on the other ear, they're at threat. Two, that good ear might be the only rope they're hanging on. And there is so many reasons for hearing loss as the age progress. So if you have another ear you could preserve, and by the way, surgical hearing preservation is durable. So if you have another ear that you could preserve the hearing with, that make a big difference. Aside from it is still, if you preserve that nerve, it is still doable with the cochlear implant. So I do hear you. The last question is what causing me the biggest trouble right now, that I do not put cochlear implant myself. That's not an operation I do. Then you need the ENT people. The ENT people are still very reluctant to put a cochlear implant where there is another opposite side with a good hearing. But they started, and the theory is coming. And what I love to hear what the Professor Borba have done in terms of taking the tumor out and putting the cochlear implant right then when he know he preserved the nerve, but the hearing is bad. Will you share with us this experience, Professor Borba?
May I say something? No, we have here a very nice ENT, very nice guy. He work a lot with cochlear implant. And in the small tumor, sometimes you don't have good hearing. And some of the patient has no hearing. See? And you have now 5 cases that we did that remove the tumor and put the cochlear implant in the same time. The problem that to do the cochlear, no, you don't do retro-sig. You need to do translab, see? And he put directly in the cochlea, see? It is unbelievable, incredible how the patient adapt itself to the cochlear implant. It's completely different when you do the brainstem implant. This is not good. The experience in the world say that the quality of the hearing is not okay, but these patients are neurofibromatosis. And this is the patient that the implant, the brainstem implant, will save life. See, the train that the Professor Omefti shows, if this guy is neurofibromatosis with brainstem implant, save his life. If there is no implant, he will die. You see, cervical hearing depend of the situation, as Dr. Omefti said. See, any hearing, I think, is hearing, but sometimes not possible to do it. Sorry to say to talk too much.
Thank you. I think it's time to proceed to our next speaker. Omar, can you introduce Professor Amr Safwat?
Can you allow me? I have one question to Professor Mufti before we start.
Okay, please go ahead.
Yes, it's just a comment about how can we choose one of 3 lines. I think it's very, you should personalize. It's very difficult to take a decision. And I agree totally with Professor Borba that one important part of taking the decision is the patient itself. And we have operated on many cases on NF2 especially, and we succeeded to improve hearing, but with partial removal of the tumor and opening of the canal, because the patient said, I will not take a risk of losing hearing in one ear. I don't want it. So opening the canal, taking the upper pole of the tumor and more is a good, you can improve the function for a while. But if you go to take out the tumor totally, you will find that you are risking, and you get some notification from the neurophysiologist that the hearing is going down. So we have to stop at this stage. So what I want to say is we have to your decision according to the patient's will. This is my comment. The questions I have to Professor Mufti is about, do you use papaverine in preserving hearing after surgery? And have you any experience with using Avastin to reduce especially in NF2, to reduce the vascularity of the tumor so you can prolong hearing preservation without surgery?
Yeah. Professor Osama, good to hear you again. First, I got a question for you before I answer your questions. Your questions is easy for me to answer. You're introducing a totally new concept for me. And I love to know if you have actual experience with it. And that is, if you decompress the cochlear nerve by unroofing the meatus, that will be like they do for the optic nerve, decompressing the optic nerve by opening the canal. Is that true in acoustic schwannomas, that if you just open the canal and take the pressure off, that hearing can be preserved? This is a very fascinating thought. I love to know if there is evidence of it.
Yes, this was not actually my work. This was the work of Professor Tatajiba. And he had a lot of experience with this, especially in NF2. And where he says, always go through the upper pole of the tumor after decompressing the canal and go from up to down. Cochlear nerve is most of the time at the lower part of the tumor. And you will have an intraoperative evidence that the hearing is preserved. I tried this with about 9 cases, and the hearing improved in 6 out of the 9, and the 3 of them remained the same. And each time I was trying to get more to remove of the tumor, I would get a very brief affection of the wave 1, and you had to stop. And we stop for some time, some irrigation and thing, it was again. So, and the patient's will of all these patients was, I don't want to lose my hearing. If I can still, you can improve it, yes, it's okay, but don't take my hearing out. So that's why we had to stop, and it worked. And I have a short experience with these cases, doing it about 2 or 3 years, but none of them the hearing regressed up till now. But of course, it is very limited number and very short. But I started this from inspired by what is doing Professor Tatajiba, Marcos Tatajiba. You know him.
I really, this is probably this morning, that's the only a kind of a concept or a question we need to debate and talk more about it. I'd love to hear what you, Professor Nasir, think, Professor Hussam thinks. Can decompressive of the meatus preserve or improve the hearing? But and now obviously we're talking here, you take the bone, you open the dura, if there is a little tumor on the surface, you could take them, but it's mainly decompression of the meatus. Can that improve or preserve hearing? A concept I did not think of before, and really worth the discussion. If it's true, it's beautiful.
Yeah, you said if it's true, then you have to try it, because there is no evidence that bony decompression alone can relieve nerve problems. Because if you have in a normal nerve, a peripheral nerve, a neurofibroma, and you just leave it, gradually the nerve will lose its function. That's one point you have to think about it, that in neurofibroma of the peripheral nerve, not central nerves, if you leave the nerve and it's growing, and there is nothing compressing it actually in the soft tissue, it's losing its function. But again, you have to try in some cases and see the long-term results. Maybe the short-term results will be good, but I don't think that the long-term results will be satisfactory. If you can do the job, then do it. The problem is in big tumors, so, or in NF. You don't want to risk what is left from hearing, but if you can do the job, just do it. Because this is just going half the way on the stairs, not up nor down. Thank you.
Thank you. The discussion, really, it's very enjoyable to all of us, but unfortunately for the sake of time, and because Professor Al-Mufti has to leave at 4:30 exactly, we have to proceed to our next speaker. Omar?
Yes, thank you for all this amazing and distinguished discussion from the panels. We proceed to introduce Professor Amr Safat to present his talk about tips and tricks in acoustic neuroma. Yes, welcome, Dr. Amr.
Hello. Okay. Can you see it now?
Yes, yes, perfect, yes.
Yes. I'm talking about very simple about the tips in vestibular schwannoma surgeries.
Your first slide does not appear, Dr. Amr. Your first slide does not appear.
Doesn't appear?
Only your desktop.
I'm trying to. Can you see it now? I'm sharing my screen now.
No, not yet. Not yet.
Not yet. Okay. I don't know.
Now it's sharing process. Yes, yes.
Yeah. Okay.
Yes, now, perfect now.
Yes. So we are going to talk about surgery for vestibular schwannomas and the advantages. Of course, it is familiar to all neurosurgeons. You are capable of dealing with any size of the tumor, any tumor, and it's a relatively rapid approach, and it allows preservation of hearing if possible. Positions you are using, of course, you all know about it, the semi-sitting, supinous elevation of the ipsilateral shoulder, and the park bench. This is the semi-sitting position. You all know the pros and cons with it. And some people, if they have problems with their arm, they are not comfortable with this approach. But if not, it is a very good approach for big acoustics, vascular acoustics, so that you don't lose your plane while working. The supine with shoulder elevation, this is an excellent approach because better than the park bench, because the shoulder will not obstruct your point of working, and you make your the nose parallel to the ground, and then you tie your patients. When you rotate the table towards you, you see more of the brainstem. When you rotate it away from you, you see more of the petrous bone. And this is where we put the flap. And of course, you know the park bench position. I don't use it. Of course, you know the skin incision, we do it 1 centimeter medial to the mastoid, and we extend it upward. I like to extend it upwards to make use of some of the fascia. If I want to close the dura, if there is a problem in closing the dura watertight, I can make use of this fascia or pericranium on the upper surface of the incision. The craniotomy, as you all know, it's a retrosigmoid craniotomy. Do the flap. The upper border will be the transverse, and the lateral border will be the sigmoid, and you do the suboccipital craniotomy. This is to show you the differences between the extent of exposure when you use the retrosigmoid, the translab, or do the transcochlear. Of course, the retrosigmoid, you have this exposure, but I agree, if you evacuate CSF, you can get a good exposure through this approach, even in large tumors, without putting spatulas. The dural incision, as Professor Sami used to do, it's a C-shaped incision inside the sigmoid and the transverse, and you leave about 5 millimeters of the dura so that you are able to close it again. And this is the difference. This is the retrosigmoid, and this is the pre-sigmoid approach. And this is when you retract the cerebellum, you can see your tumor and the vestibulocochlear nerve. And this is an operative view where you see the sigmoid and the transverse You don't use spatulas, just you can reach the cerebellopontine angle after evacuating CF. And this is Professor Sami classification, very simple, intracanalicular, intracranial without touching the brainstem, third grade 3 touching, and grade 4 compressing the brainstem, A without hydrocephalus and B with hydrocephalus. The vestibular schwannoma arises usually from the superior vestibular nerve. As I said, usually, Professor Al-Mufti will not be angry for me. I said usually. And as he showed us today, it can arise from the inferior vestibule, it can arise from the labyrinthine branches inside the canal. This is a rapid anatomy of the, the transverse crest here and Bill's bar. And the anatomy of the cerebellopontine, you see that the 7th and the 8th nerve, and see the pica is elevated here. You see the ica and the subarcuate artery and the internal auditory artery, 9 and 10, 11 cranial nerves. And this is an operative view. And after opening the dura, you will see here the cerebellum, and you can have a microscopic view where you see this is the 6th or the 7th nerve, and this is an endoscopic view. It's a wonderful view. This is the left side, this is medial, and this is lateral. You see the petrosal vein, you see the trigeminal, you see the 7th and the 8th cranial nerves, and you see the lower cranial nerves. So the endoscope is a wonderful tool. You can use it to help in acoustic surgery. The tumoral anatomy, extending from the canal or the medial type, totally medial, and going towards the brainstem and the facial nerve. This is an anterior view where the facial is displaced anteriorly. The view. So the surgical steps after craniotomy and dural incision, from 1 to 4, evacuate CSF, so that no spatula is needed in the supine or the park bench position. In small and medium-sized tumors, you drill the internal auditory canal. In large tumors, do internal decompression first. Sometimes it's very difficult to reach the canal with large tumors. So you do the internal decompression first and then start drilling the canal. The canal is exposed, as Professor Al-Mufti showed us, by peeling the dura posteriorly and drilling for a distance of 1 centimeter. Let the pull of the tumor, as Professor Osama just said, be from medial to lateral and not the reverse if you need to preserve hearing. This is a view of the canal, internal auditory canal, the 7th nerve, and you do the extent of the drilling. It's a more magnified view. And you peel the arachnoid from the tumor and use hydrodissection. This is, I was taught from Professor Sami, he doesn't use too much dissectors. He just does 2 forceps. One, the tumor holding forceps, and the other is an untoothed forceps, thin out, and he starts to peel. Actually, he peels the arachnoid from the tumor, and every now and then he does a hydrodissection, dissecting the plane between the tumor and the arachnoid. And this is, of course, to separate it from the trigeminal and from the lower cranial nerves and from the brainstem, but not from the facial being too adherent to it. You find the facial nerve internal auditory canal, and then you dissect the lower pole of the tumor and identify the facial nerve at the brainstem. And in between, as Professor Borba said, it is difficult, so you have to use the electrophysiologic monitoring. The facial nerve is usually at the anterosuperior pole of the tumor, and the most adherent part of the facial nerve to the tumor is at its entrance into the canal. So when it goes into the canal, is the most adherent part. So expose the facial nerve inside the canal, expose the facial nerve at the brainstem, and then do internal decompression, take the lower pole, elevate it up, and try to find the facial by neurophysiology, and leave the last part to be taken out is at the entrance of the facial nerve into the canal. This is a diagram showing also the relation of the facial and the cochlear nerve to the tumor. And these are actually the different situations. It is anterosuperior, or the facial nerve is anterior, or anteroinferior, or very, very rarely it is posterior. And this is an intraoperative photograph showing the acoustic tumor and the lower cranial nerves and the facial in front. It's an operative view. The dewar should be closed, watertight, and the bone replaced with, which greatly reduces post-operative headache. I know that many people here in Egypt, they do a suboccipital craniotomy, but even if you do the craniotomy, if you preserve the bone and put it in a piece of Surgicel and put it back again, this would be perfect to reduce the incidence of post-operative headache if you don't do a flap. This is one of the cases I operated, and this, of course, this case, the hearing was lost, unfortunately, as Professor Osama said, and it was not the concern of the patient. And this is the follow-up. And this is another case. Very commonly you can find arachnoid cyst with the tumor, more space you can reach, and this is the post-op. And I just want to show a clinical case with a 31 years old male complaining of gradual progressive diminution of hearing since 3 months. And he had not a small, medium-sized acoustic neuroma, goes part of it intracanalicular, part of it inside the skull. And this is the coronal view. And in this patient, the hearing was preserved. The ear affected, the left ear, and the hearing preserved. And this is the post-op. The left, it diminished a little, but it's still serviceable and still using his ear, and he still can use it even to talk by phone. I have a video. Sometimes I have problems with videos, and I will try to get it now.
No.
Yeah. Yes, I will try.
No, not yet, Dr. Am.
Yes, I know. Because sometimes.
Could you please say the text until this video works?
Yes. I try to be very fast in my talking.
Thanks a lot. Thanks a lot.
Maybe, yes.
Could you allow me to speak by the time you get the video?
Yes,
One
yes,
thing about acoustics, and Professor Mufti said it, that don't use the bipolar except under extreme.
Is it okay?
We use usually continuous. Yeah.
Can you see the video?
No, not yet. Not just your
No.
desktop. Only your desktop.
I just, by the time you bring, we do hydro dissection by continuous irrigation. And one instrument we don't have is the irrigation suction tool, which is very effective. The other thing, to Professor Osama, when doing the transmastoid, you have to check the jugular bulb, because if you have a high jugular bulb, you may put the patient at risk when you are doing the mastoid flap. So for those going, don't overuse your bipolar, because usually you don't need it except in a small amount of acoustics, the fibrovascular type, and these are really terrible things, or in sometimes in the cystic adherent vascular acoustics. The other thing, always check where your jugular bulb is.
Your opinion regarding the question of Dr.
Thank you. I think Professor Mufti put it beforehand, but I am still stressing about these 2 points, because usually I see that at least in our part, there is an overuse of bipolar coagulation. And when you do that, you just lose the arachnoid plane, a trick put by Professor Al-Mufti and shown in his videos. You always try to find the arachnoid planes, and in big acoustics, you just lose these planes at the region of the brainstem. This makes the problem, and sometimes you have to leave a residue. Thank you.
Professor Mufti, are you still here?
I'm with you.
Yes. Welcome. Please, your opinion regarding the questions of Dr. Husseini, please.
Waiting to see Dr. Amr video.
Yes.
But
I really always have problems sometimes with this videos.
Two things. So perfectly what it said with Dr. Al-Husseini, Professor Al-Husseini. The bipolar is a big deal. It burned the nerve, and the labyrinthine artery too get burned with the bipolar. And that's where the hearing is. The hearing is not just the nerve, it's not just the cochlea, it's that labyrinthine artery too. And it's so small and so easy to coagulate it on the surface of the tumor. Now, I hear the Hisham, good to have you here, and good morning, and haven't seen you for a while. But to Professor Amr and to Hisham and to everyone else, doing suboccipital craniotomy, that's what you sigmoid. In other words, without to remove the mastoid and the flip the sinus. Mandate sitting position. You're getting away with it because of the sitting position. You're looking at the tumor from below upward. So you do not need the maximum retraction of the cerebellum if the patient was in a supine position, because you are not out lateral enough. So almost if you don't want to do just the traditional retrosigmoid approach, it's almost a must to do sitting position. Now, for people, including myself, who train with sitting position for years and years, might not be that a big problem. But you have to know that many places, the anesthesiologist and the whole sitting up, it's not comfortable with patient in sitting position, nor has an experience with handling the complication of sitting position. And that's why a lot of places has shied away from sitting position. So what I'm saying, if you just want to do suboccipital craniotomy, you need a sitting position. And what I'm saying, sitting position, it's not that easy for a lot of places that do not have a routine experience with it.
Well, that's a good comment. I think Amr had his video now, so we can see it. But
yes, I was trying everything, and but it's very interesting question, Professor Osama. As I told you, with vascular tumors, I prefer very big tumors, vascular tumors. I prefer the sitting, but I know that with sitting you have to use a spatula, so that's what I don't like in the sitting position. But it keeps me always keeping my plane clean. when the patient is sitting. That's why I'm sometimes forced to do it. I don't like to use spatulas, but I get a very good plane. That's why sometimes I do it. This is the video of the patient I showed you, and where we preserved hearing, and we are going to apply some of the rules I just showed you. And as Professor Osama said, he's my mentor, of course, and talking after a great mentor is very difficult. But I can show you what I can do. I peeled the dura from the bone, and I'm reaching now the internal auditory canal. And to save time, I'm drilling the bone. I'm doing a diamond drill for a distance of 1 centimeter to expose the intracanalicular part. Of course, this case, the tumor was not big, was not large. So I started by exposing the tumor inside the canal before going into the big tumor, the intracanalicular, the intracranial part. And this is after taking the bone. And this is the intracanalicular part. And again, you should remember all the precious advices from Professor Osama, that you go from medial to lateral if you want to preserve hearing, never the reverse, not to pull on the cochlear nerve. And we are working inside the intracanalicular part here, and then gradually we remove it piece by piece, and then we shift to the intracranial part. We do an internal decompression according to the consistency of the tumor. If you need the CUSA, it's okay. If you don't need it, you can do it with the scissors. You can do it with pressing of the tumor several times to soften it and remove it piece by piece. But never pull on the tumor. This is, we are trying the internal decompression. And of course, after this internal decompression, we will find, this is the lower pole of the tumor. As I told you, we remove the intracanalicular part, we are internal decompression, then we are exposing the lower pole of the tumor, where you can find the facial nerve at its exit from the brainstem. All my work is from medial to lateral. More internal decompression and more dissection of the lower pole. You can see arachnoid here, keeping the lower cranial nerve safe. As we said, hydrodissection. Look here, the tumor, the lower pole and the medial part of the tumor are coming. Here you can see the facial, very well seen from the brainstem. I do stimulation to make sure it is the facial. Now I'm sure it is the facial. You should always be suspicious of everything. If you have the tools, it's not wrong to confirm and reconfirm. This is the attachment of the tumor to the vestibular nerve. And this is, you get more plane. Going from the medial pole to the upper pole of the tumor. Hydrodissection, as I said, is very important. taking small pieces of the tumor. In this case, it was not a must to use a Cusa. The consistency allowed to be taken by scissors, allowed to be taken by forceps. And this is to show you how we are taking the last pieces. This is the intracanalicular. It was dissected, kept in place, and this is the facial nerve from the canal into the intracranial cavity, and this is after we took out the intracanalicular part. And I think that's it. Thank you very much.
Thank you very much, Professor Amr Safwat, for this great talk. I think for the sake of time, we have to proceed again to Professor Osama Al-Mufti. We just have 40 minutes and we have to close this webinar. So we have to proceed to our next speaker, Professor Osama Al-Mufti, Management of Cavernous Sinus Meningiomas.
I have to stop sharing my screen.
Can I add a comment because of the sitting and semi-sitting position?
Hisham, can we make the comments after Professor Osama talk, because unfortunately we have to close the webinar 4:30 exactly after 40 minutes.
Professor Mufti has an obliged commitment and he needs to leave.
After 40 minutes, Professor Osama Al-Mufti, he has a very important commitment. We have to proceed.
I'm trying to get to share the screen. Just give me 1 second. I will get it.
We can see the screen now, Professor Osama.
How about now?
Now it's full screen. It's perfect.
Perfect
yeah,
now.
Okay, good. Now, just give me 1 second. Let me start from the beginning.
Yeah.
Now, you asked me about the subject I have not been talking about. So, and I have not been talking about because I got hoarse voice talking about it. And it seemed like I cannot convince anybody in this world. And I cannot understand why. And that is cavernous sinus meningiomas. It seems like everybody has made their mind and really not receptible to see what the data is and the experience. So this is one of my early cavernous sinus meningioma. It was, I think, it's about 1985, this patient per se. And, at that time, I'm a young man, excited with the new techniques, and have done several cavernous sinus meningiomas. So I got this, I will do her. And sure, I did get her tumor out, but that's how she was left. young teacher. So I don't come to a cavernous sinus meningioma without insight. From early on, I knew that this is a subject required a lot of consideration. It's not gung-ho going into the cavernous sinus. It's a very thoughtful and learning experience. But today, and this is maybe a year ago case, I have no hesitation of removing a cavernous sinus meningiomas. And I do expect a curative total removal, not in all of them, but in many of them. And I'll show you the numbers. And I do expect a beautifully intact patient. But this patient is not quite intact. You know what's wrong with her? She tilts her head a little bit because she still have the fourth nerve to recover. But it will. This is just a couple months after surgery. So let me tell you about cavernous sinus meningioma the way I experience them. By the year 2000, my golly, that's 20 years ago, I had already 346 cavernous sinus meningiomas. And right away, there are two types, so you cannot put them together. There is those are cavernous sinus meningioma proper, like the one on the left side. And there is those, the one have invaded the cavernous sinus from the surrounding, clinoidal meningioma, sphenopetroclival meningioma, medial sphenoid wing meningioma, etc. So for time is short, let me just talk about the cavernous sinus meningioma proper. Many of them is like this one, especially now, a patient has a headache, got an MRI, or for a reason or another, or found just a small monkey incidentally. However, you got a real cavernous sinus meningiomas that has grown to inflict deficits, and it is growing. These are the big monkeys that needs the treatment. For the small one, we were doing this treatment, the N-knife. Look at it, beautiful control from 11 years. She's like many others. Here another one, another 11 years, beautiful control. Enough to have a baby and two. You're wondering what this magic N-knife is? Omar, take a quiz. What's the N-knife?
Okay, okay. All of us, we don't know what's this actually.
Look at this. I even put the N-knife, the font in.
I think the N-knife is no knife.
No knife, absolutely. N-knife is no knife. And look the results of that N-knife. The 5 years control, 90%. 10 years control, 82%. 20 years control, 72%. Complication, 0. That's not me. That's this University of Paris. Now, if you get the results then of L-knife, you know what L-knife is? Linux or electron-based accelerator treatment, radiosurgery. Here it is, 5%, 92%, 10 years, 82%, but the complication is 19%. Here's the gamma knife. 5 years is 94%, 10 years is 86%, complication 11%. So if you put them side by side, no knife, Linac knife, gamma knife, in terms of a tumor control, they're so similar. The only thing about the no knife that there is no complication. And that's not surprising, because if you take over all the meningioma that is treated and look what happened about 10 to 12 years, the control dropped to 50%. This is not my finding. These are the expert of gamma knife. More, look at this one. If the tumor was not growing before you give radiosurgery, if the tumor was growing before you give radiosurgery, control, it dropped to almost less than 20%. So if a tumor is growing, radiosurgery does not control. If the tumor is not growing, he needs no radiosurgery at all. It's self-control. But unfortunately, many of these small incidental cavernous involved meningiomas today in here and everywhere around this world is like this patient. It find incidental small meningioma. It may be observed for a year or two. It may be thought, well, maybe there is a minimal growth. Then it gets radio treatment. This one happened to be proton radiosurgery. Shrink. Beautiful result. It reoccurred 10 years later with aggressive growth in the cavernous sinus. So still the same fear, we don't operate on the cavernous sinus, we cannot remove a tumor totally from the cavernous sinus. We do a partial removal to avoid complication. Well, the complication does happen with partial removal too, like you see that infarct right in the internal capsule. Then after your partial removal, it keep on growing. Then what do? You start all of this protocol on medical treatment. It keep on going. You give it more radiation. It keep on going. The metastasize. It's a frank out malignant tumor, and the patient died in about 10 years' time. If it's not for anything, but for the small cavernous meningiomas, we should stop radiation. I'm saying that because that's what the prime of candidates for radiation out there. I think we should stop radiation for all meningiomas. I think we should stop radiation for all benign brain tumors. Why they're radiating? Because it says so dangerous to operate on meningioma in the cavernous sinus. You got bleeding, they die. It's a big deforming operation. You got cranial nerve deficit that mess up the quality of life. So why would you go there? Well, we go there because the tumor is there, and taking it out and not taking it out is the limiting factor from radical tumor resection that give relief and cure. And it's not a new thought. It's a more than 130 years old thought where Ali Krogus has removed meningioma from the cavernous sinus. They had the indication then, and it's still true today. So what do you do with hemorrhage, bleeding? The veins do not bleed if there is a tumor. The risk is obviously the carotid, and like any major artery, if you want, you have to have a proximal and distal control on it to be able to handle the bleeding. So you gotta know the anatomy. This is not a beautiful anatomical jewel box. This is a beautiful surgical, microsurgical jewel box. Just, you gotta know where you are. You have to know the anatomy. You gotta know what you're doing, where you are. So the study of the cavernous sinus anatomy was very extensive 20 years ago. And we all came with those 10 triangles. Those anatomical triangles are small windows. If you want to remove a meningioma from the cavernous sinus, you really need to open doors. And that means either the lateral wall of the cavernous sinus or the superior wall of the cavernous sinus, and on occasion, the posterior wall of the cavernous sinus. And most of the time, the combined three doors, superior and lateral, and likely posterior. So you want safety? That's a jewel box. That's like the bank jewel box. Need two keys. One proximal and one distal. We called it the unlocking of the cavernous sinus a long time ago. The proximal is in the petrous apex. The distal is the subclinoid carotid. And then you got the bone outside the cavernous sinus in particular. Here an example of it. The whole middle fossa bone is involved. So the middle meningeal, coagulated, cut, and the spinosum plugged. Then you could see all of the bony drilling into the floor of the middle fossa, drilling between V1 and V2, drilling under V2, lateral wall of the sphenoid sinus, here V2, here V3, a little bit more drilling. So part of the meningioma in that area is the involved bone outside it. Now peeling up more, going under the V2, under the rotundum, all the way into the sphenoid sinus. All of that bone is invaded bone. What's that mean? It's really your easier part to operate is the soft tumor inside the cavernous sinus. You could see here between V2 and V1. Then you could open your dura and work on the intradural port. Here an example of the intradural port being operated and radiated before. So a lot of adhesion. So you could see spinosum, bone over the petrous carotid, securing the petrous carotid canal with the Fogarty catheter, taking the anterior clinoid out, relaxing the dura fold, opening the dura, a lot of adhesion, devascularizing from the floor over the sphenoid ridge, the middle cerebral artery, the lateral wall of the cavernous sinus, entering from the superior wall. You could see the carotid and the tumor removed from the superior wall. There is a plane between the carotid and the tumor. Bleeding, yeah, could happen. It's an avulse of a little feeder that easy could stop. I hope the video is showing well without jerking and jumping and lagging.
It's perfect.
Yeah, no, it's perfect, perfect, perfect.
Here the big involved anterior clinoid, opening the optic canal, removing the tumor from underneath the optic nerve, removing the tumor from under the carotid. Look, the posterior loops of the carotid in the cavernous sinus. Pulling out more the roof and the lateral wall. You see the third nerve coming, taking it off the third nerve, going all the way back now to the petroclival posterior wall of the cavernous sinus. Here, Lilliquist membrane. Here, the petroclival ligament and Dorello canal and the sixth nerve coming. So you see carotids, anterior loops, posterior loop, lateral loops, optic nerve, third nerve, V1, V2, V3. And here the fat filling up. The white is fat. It's not tumor anymore. Do fat suppression. This case is an old case before even fat suppression sequence can develop. What I'm saying many times, the carotid, here we're looking for it with a Doppler, has a nice plane between the tumor and the carotid. That's all you could see it. Carotid down here in the cavernous sinus, following it upward. In about 2/3, 68%, 65%, there is the plane you're seeing right there, which make it easy to remove the tumor of the carotid. Now, but that's not always the case. Now, well, so in general, you get the cavernous sinus meningioma like this. You go down on the middle fossa. You get the petrous carotid canal. You get a control of the petrous carotid. You take the anterior clinoid out. Here, drilling the anterior clinoid, removing the anterior clinoid. Opening the optic canal. Put electrode for the third and sixth nerve directly into the muscle of the eye. And you're exposing it because that's the cranial orbital zygomatic approach. The bone invaded on the floor is removed. V1, V2, V3 is peeled off. The tumor removed between V1 and V2. Here, the carotid artery down there. And after you finish the extradural, you open the dura. There is always a tumor in this protruded intradurally, here between the optic nerve and the carotid, here opening more the carotid canal, the optic canal, the tumor underneath at the petroclival area. You could see opening now the third sleeve into the cavernous sinus, crossing over the optic canal, cleaning the optic planum meningioma, dura. Going backward now toward the sixth nerve. Right there, we got the tumor over Dorello canal. Right there. That's the petroclival ligament coming down and removing the tumor from around it. Optic nerve, carotid, third nerve. A little bit more tumor. And it's gone. And that's what happened. Look at her. She woke up, ophthalmoplegia in that eye. A week later, before coming to take her suture out, I still have ophthalmoplegia. 3 months later, recovered. Yes, by dissecting so much in the cavernous sinus between those nerves, it will be a good number of patients with immediate postoperative worsening of oculomotor function. 80% of those are transient and they have a year to recover and return to the original function. Bigger tumor is even easier. A tumor that back into the Mickle cave more than the anterior cavernous sinus is even better and easier. They're delightful. For reason or another, there is no invasion of the nerve when they are growing into the Mickle cave. They pull out so nicely from Mickle cave. You can see we're in the middle fossa, greater petrosal nerve, lifting up the outer layer of the sinus, opening the Mickle cave, seeing the fifth nerve ganglion and branches, rootlet, and seeing the tumor. Look at the tumor. And here you avoid the injury to the rootlet and just remove the tumor, which is usually very nicely, easy removable. I don't know why the tumor in the posterior part of the cavernous sinus is a less adherence and easier to remove. And here she is. And many of those patients in the posterior cavernous sinus, they will have, in Mickle cave, they will have facial pain and occasionally even trigeminal neuralgia, and it get relieved by taking the tumor out. Now, then you get a tumor like this one. especially I call those the sphenopetroclival meningioma, but they are filling up the cavernous sinus. And more important, look at the carotid. The carotid is narrow because of the construction from severe adhesion of the tumor around it. So you come in to operate, middle cerebral, middle fossa, peel off from the third division, peel off from the second division, drill the petrous apex, which invaded by a tumor. You see, all of that petrous apex is a tumor. So everything medial to the petrous carotid is a drill. Here we are in the posterior fossa through the petrous apex. Now we're going back, peeling off rotundum. And up toward the superior orbital fissure. And here the superior orbital fissure. So we got V3, V2, the petrous apex removed, the petrous carotid preserved and controlled. We still extradural. Now we're removing more bone between V1, V2 and V3. Always there is a tumor invading that pterygoid plate. Here the anterior clinoid now. The anterior clinoid, it's all a tumor also. So it's removed. Be very careful with the drilling of the clinoid these days. What we're calling diamond bit, they are not really any more real diamond. They have a spike in them, no matter how fine those spikes. They injure vessels. So you gotta really be very careful. Now here we enter the sphenoid sinus following the tumor from between V1 and V2 and removing the tumor from the wall of the sphenoid sinus with the endoscope. So this is a transsphenoidal, but the transcranial transsphenoidal instead of transnasal transsphenoidal. But anyhow, look what happened. This is all fat we put. But we have to leave this piece of a tumor around the carotid artery. It's so adherent that does not suction or remove or dissect like I showed you in the beginning. And that happened probably about 35% of the time or more. So we leave that little piece of the carotid. We do not risk the carotid. The carotid is too great things to waste. His ocular movement will recover. And here the bottom line. And I close. Patient come with 6 nerves. You operate, total ophthalmoplegia. 3 months later, the 3rd nerve that surgery induced start to recover. A year later, what you gave them will recover 80%. What the tumor has originally gave, that in her case, the sixth nerve, very few recover. That was true in 1994 when we had only 50 something tumor. And that's true when we reviewed 163 cases 10 years later. Because those meningioma on some time infiltrate the nerves, so they will not recover if they were already paralyzed. Yes, you could remove cavernous meningioma out. You could do it in about 65, 68%, and that's a permanently cure. So how forbidden cavernous sinus meningioma surgery? Not at all. Thank you.
Thank you very much, Professor Osama Al-Mifti, for this very illustrating presentation. I don't know if we can have some questions or comments.
Yes, may I have a few comments and for Professor Al-Mufti?
Okay.
Hello.
Please go ahead, Professor Osama Al-Ghandour.
Yes, Professor Osama Al-Mufti, thank you very much indeed. We enjoyed your work indeed. But just I can guess this operation is going to be easy or not from the MRI. If I look at the carotid artery inside the cavernous sinus, if it is normal size or even larger, I wouldn't be worried, because this means the tumor is from outside the wall. It's outside the armored lateral wall of the cavernous sinus. But if the carotid artery is smaller or compressed than the opposite side, I would say it's inside the cavernous sinus. So I have to prepare myself to and this is of course against the general rule that the tumor drive blood supply from a nearby artery. So it's become large. But in case of the intracavernous sinus, all of them are entrapped inside that will be so compressed in comparison to the opposite side. What about that? Have you seen that before or noticed that? Thank you.
There was a cut off the sound in the last thing, so I missed the last point of the question. I'm really sorry.
Well, about the relation of the carotid artery into cavernous sinus meninge. If the meninge is inside the cavernous, I would see the carotid artery is smaller. While if it is outside, but it's attached to the lateral wall, the carotid artery is the same size, like the opposite, or even larger. That's what I've noticed. That's why I can plan my surgery in advance. Am I going?
I restricted my talk.
Open the cavernous sinus, or just the whole lot is on the outside. So I can
restricted. Yes,
you restricted
yes, sir.
what?
I restricted my talk to the intracavernous sinus meningiomas.
Yes, but some of them are
outside. They all penetrate the dura and have some presence outside. Sure.
Well, this make life easy. I mean, if
there is no extradural total removal of cavernous sinus meningioma, because that meningioma is that dura is involved, need to be removed. Now, the carotid artery, here's the story of it. If you have a clinoidal meningioma pushing on the lateral wall or temporal meningioma pushing on the lateral wall, those are easy. the carotid is not involved,
Yes.
the nerves are not involved, then one just have to separate. Now, if you have a truly cavernous sinus, either invasion or improper, then you have two situations. Either that carotid artery still have a plane around it, or no longer have a plane around it, and there is a severe adhesion and distortion of the adventitia. That severe invasion and distortion of the adventitia, both Dr. Delank and Dr. Shaker and many others called it invasion of the carotid. If you want to call it invasion, or you want to call it like what I'm calling it, severe adhesion and distortion of the adventitia, it cannot separate it. You cannot take the tumor off the carotid. And that's what I'm saying. And this, unfortunately for me, I do not know till I am in surgery tried. There is a few hints on the imaging. There is a possible narrowing, or more than narrowing. Narrowing could still be able to remove the tumor. Beading, you know, there is a narrow space, and then there is wider, then there is narrow, then there is wider on the carotid, if you see that on a vascular study. So I agree with you. There is many cases where the carotid, call it invasion, or call it disturption, you cannot remove the tumor of the carotid. You might have a hint from the preoperative study, but you really does not know it for sure till you are in. Narrowing at all, it's not definitive.
Professor Luis Borba, do you have any comments to Professor Osama Al-Mufti?
Oh, I'm following him all the time. You know, I'm still worried about I think the most important cavernous science today is to understand, as the Professor Al-Mufti showed, our limitations. Sometimes you can do, sometimes you cannot do, but you should try. Sometimes you do the surgery, you believe you don't have plan. When you arrive there, there is a plan and you can go and take it. But understanding the anatomy, understand the way, it's the most important thing. And the other thing that is worrying a lot, the case that I will do tomorrow, a 54 years old lady has had a small tentorial meningioma. Not cavernous sinus, tentorial meningioma. Had facial pain. They decide to do radial surgery. Okay, the tumor shrink a little bit. 2 years, perfect. But paresthesia. Now she has anesthesia, pain, and the tumor grow again. If I can, maybe I wanna, there is one, if I have 1 second, I don't know if I can open here. I don't have here, I wanna show you one slide, if you allow me.
Yes, please.
To see how the world today is crazy. May I share this slide?
Yes, please. Go ahead, Louis.
Just see it. Look at this, please.
What's that, a gamma knife?
No, efficacy of stereotaxic radiosurgery for radiation-induced meningioma. And look the size of the meningioma, the example of the article. Man, this tumor, you can give 10 centimeters margin, not 2 centimeters as Professor Adiboke. See, it's crazy. And when you go to see the authors, a famous neurosurgeon around the world that giving lecture about skull base, you do everything you can do, remove, you have my endoscope, you have my microscope, you have my... I don't know how to stop it to share it here.
Professor Borba, put that slide of the article again. Because
I'm trying to come back here. Let's try to come back. No. What?
Go back. Go back to that article. I think you just showed where is the major problem in the world of neurosurgery today. Put that article.
Yes.
Can you put it?
The whole article?
No, just the title.
The slide. Can you see?
Yeah, just the title. I think this is a very, very important point.
Only the slide again.
Can you share your slide again, please?
Okay.
This one.
Yeah, put it big. Whole screen. And read the name of the authors.
No. It's difficult to understand. Everybody can read, Dr. Mefti.
The senior authors are professors of neurosurgery who's taking the leadership and who are on the podium giving all the lecture and the things and will examine you.
Yes. This is the main point.
This is where the problem.
Yes.
We know radiation-induced meningiomas does not respond to radiation to start with. We know it's a bad that needs to be removed and removed with margin. We know if something on the convexity is so easy to remove with a minimal risk. But we have our master surgeons saying that we need to give this radiosurgery. That's where the problem, I think, today in teaching neurosurgery. That's what the young neurosurgeon and residents are learning, that this is a small meningioma on the convexity, that you could give it radiosurgery.
Then in the worst is radiation
I think
induced
that's
meningioma.
what needs to be discussed on a wide range in the world of neurosurgery, the teaching and the training of microneurosurgery in our specialty.
Yeah. Let's stop here. We start to cry, Dr. Alberti, if I show another one.
Thank you very much. The discussion is really enjoyable. And sorry that we are extending the webinar after 4:30. But when you have masters of skull-based surgeon all over the world making such discussion, we are all getting benefit from this discussion. Thank you, Professor Luis Borba, for this contribution. And I think we have our last speaker, Professor Hussam Al-Husseini, and I will appreciate if he can squeeze his talk in 10 minutes in order to be able to close this webinar.
Could we postpone this? Could we postpone, Nasser, this talk to another webinar?
If you are accepting, we will appreciate this much, Hussam. We are sorry about this, but as I said before, that the discussion was very enjoyable.
4:40. Yeah.
Yes. And Professor Mufti has a very important commitment.
Yeah, I know, and I think we are all tired after more than 2.5 hours. So if we can postpone it because you cannot
Okay.
squeeze it in 10 minutes, this is
Okay.
one,
Okay.
and we are off time.
Okay. And so by this,
I go with that.
thank you. We appreciate this initiation, Hussam, very much. And at the end of this webinar, I would like to thank our honorary guest speaker, Professor Osama Al-Mufti. Thanks for accepting my invitation. Thank you very much. You honored us by contribution to this webinar, and thank you for being so much patient to ask to respond to all our questions. I would like to thank Professor Luis Borba for contribution to this webinar and for this valuable discussion and comments. Thanks to our distinguished speakers, Professor Amr Safwat, Professor Hussam Al-Husseini, or our panelists, Professor Muhammad Al-Fiqi, Osama Al-Ghannam, Hisham Basyouni, and everybody who contributed to this webinar. Thanks to Omar Youssef. Thanks to all attendees. Thank you very much. And I hope to see all of you again soon in another occasion. Thank you.
Thank you, Professor Nasser. I'm sorry about that. I talking from Hurghada, and then it sometimes cut off, but I couldn't miss you and your meeting when sharing with you. But I enjoyed, I must say, I enjoyed all the speakers and discussion as well. They enrich our knowledge about it. Thank you very much indeed.
Thank
We need to invite Dr. Mufti to Hurghada with you, Dr. Osama.
Well, yes, when I talked to him while I was walking on the seashore.
Are you ready, Professor Mufti, to be invited to Hurghada or not?
Yes, everybody, not just Hurghada, to Hurghada or in summer into Marina. Lisan al-Wazara is waiting for you. Everybody there. We're enjoying having everybody of you there.
Thanks a lot to all professors.
Thank you.
Thank you.
Thank you. Thank you, Professor Al-Mufti. Appreciate it.
Thank you.
Thank you very, very much. Thank you.
Thank you.